Can you hear me? Yes? I just want to thank Gilda for a very interesting range of information. Hard to assimilate, I think, but bear in mind that her paper, as well as the slides, will be on the website, on our website, and you consult it if you can consult the website, and you can consult the paper and the slides. And of course there is also the article in the Lancet, which is very, very interesting. And we will have the Q&A session shortly. Our next speaker is Dr. Patricia Lohr, and is the machine working, she asked? Yeah.
My slides couldn't tolerate the aspect ratio, so thank you very much for inviting me to come and speak with you today. My goal in the next 15 minutes is to try to give you a picture of the experience of and the concerns of really the majority of women who travel from Ireland to have an abortion in Britain, who don't have, for example, a serious fetal anomaly. British Pregnancy Advisory Service is a charitable provider of abortion care in England and Wales mainly, and we treat, although we do treat women who are coming for terminations for fetal anomaly, the majority of our patients are not coming for that reason. The way that I'm going to talk you through the experience of the majority of women who are traveling from Ireland, and also to give you a flavor for how that compares to what the experience might be like for someone who is from Britain. And I think it is important that we distinguish between what happens in Scotland, England, and Wales, and what happens in Northern Ireland, where the Act allowing abortions to be terminated, allowing abortions to occur in certain circumstances does not extend. So I'm going to compare the experience of Siobhan from Ireland to a woman called Charlotte from England. And they start out very similarly. They are 21 years old. They both are partnered. They have boyfriends. They are both studying at university. Both of them were taking the birth control pill. And both of them think that they're about 6 weeks pregnant by last menstrual period, having missed a couple of pills in their last menstrual cycle. So let's just talk a bit about who has abortions in Britain. You've just had an excellent overview of worldwide statistics, and so some of this is going to sound familiar to you. So it's estimated that about 1 in 3 women in Britain will have an abortion in her reproductive lifetime. And those women come from all backgrounds, all races, ethnicities, religious backgrounds, demographic characteristics, as long as they're of reproductive age, and socioeconomic backgrounds. Looking at the reports that are produced about abortions in England and Wales and in Scotland, although the focus of my comments are going to be about statistics from England and Wales, we know that most of the women who obtain abortions are white. Most of them are single, although that counts women who may have a partner, and actually more people describe themselves as single with a partner than single without a partner, and most are in their 20s. Interestingly, though, there are variations in certain age groups. So more conceptions that happen in teenagers end in abortion than in other age groups. So even though the numbers of teenage pregnancies has declined dramatically in England in the last 10 years, it is still the case that over 60% of those conceptions end in abortion. And similarly, for women who are over the age of 35, a larger proportion of pregnancies occurring in women over the age of 35 end in abortion. Minority and ethnic groups are overrepresented compared to their proportions in the general population. And we know, particularly from data in Scotland, that economic deprivation and abortion rates are related. And this is understandable if you think about the fact that one consideration that a doctor or 2 doctors may make in determining whether or not a woman is eligible for legal abortion in England is about the potential impact on her other children. So if people have other children and they are also struggling financially. They may not be able to afford another child. About 1/3 of women in Britain have had more than one abortion, and this proportion is rising. And similar to what Gilda's already presented to you, over half of women who have an abortion already have a child. So why do women choose abortion as opposed to adoption or parenthood? We know that over 90% of pregnancies ending in abortion are unplanned pregnancies, so women were not trying to get pregnant. And that's for a range of reasons. A large proportion of those are because they were using a contraceptive method that failed. So as in the case of our Siobhan and Charlotte, the birth control pill is not 100% effective, even when it's used exactly the way that you are supposed to take it every single day at the right time of day. Some people don't use contraceptive methods. Some people were coerced into having sex and so hadn't planned, for example, to do that and so weren't using a method to prevent pregnancy. And there are a smaller proportion of abortions that occur for maternal or fetal indications. As I've said before, I'm not going to address those. But the pregnancy being unintended in and of itself is sort of just a first level reason, really. There are lots of things that underlie the ultimate decision that a woman makes to end that pregnancy by abortion. They're typically multiple and complicated, but some common themes are that they understand the responsibilities of parenthood. And so for young people, for example, it's an understanding of whether or not they are ready to be a parent. For some people, it's about timing and family size and understanding what's needed in terms of the energy, the resources, the availability of oneself as a parent to bring another child into the family. Financial constraints, as I've already discussed, is important, and lack of partner support. But this is only a small sample of the reasons that women give for choosing an abortion. So let's go back to our Siobhan and Charlotte. So both of them have a talk to their partner about the fact that they think they might be pregnant, and to their sister. And it is certainly the case that most women who come to see us will have already spoken to people around them, including their partner, before they call us to schedule an appointment for a termination of pregnancy. They have made the decision before they contact us. What I would say is, although I have put the same language under this for both Siobhan and Charlotte, it is the case that women who are coming from Ireland tend to have a much smaller circle of trust, fewer people that they've spoken to, fewer people that they can tell about their potential decision to terminate a pregnancy because of their concerns about stigma. Both of them want to finish school, both of them want to be married before they have a child, and so both of them make the decision that they want to have a termination, and they do a web search, as you do, Googling abortion, and certainly for Siobhan, adding in the UK. So how will their pathways differ from this point? And this is where things do start to look very different. So for Charlotte, in England, she will be able to refer herself to the abortion clinic. She may be able to go to her GP and get a referral. She may be able to go to a family planning clinic and get a referral. There are a number of different pathways into services. For Siobhan, she doesn't have that option. She can only refer herself. For Charlotte, the time that it will take for her to get into consultation and treatment largely depends on convenience, because abortion clinics are many and appointments are readily available. So it's her decision when she's ready to come in. For Siobhan, it will largely depend on her resources, because of course not only will she have to gather together the money to pay for the abortion, but she'll have to gather together the money to travel, and for some women, they will have to make up a story about why they're traveling, because again, they're concerned about stigma, shaming, ostracization that could happen from people knowing that they're planning to have an abortion. For Charlotte, she'll be able to access clinics locally, of course. And for Siobhan, she will have to travel to Britain. And for most women coming from Ireland, they make an overnight stay, because even if they're having their consultation and treatment in one day, that typically happens quite early in the morning. So some women may get on a plane at 5 in the morning, much like I did coming from London to talk with you today. But for some women, particularly if they're remote, they'll have to travel by train, then get a plane, then stay overnight before coming to the clinic. Both of them may need an escort home. particularly if they're having their treatment under general anesthesia or some sort of sedation. They need someone to look after them. And of course, that involves, for women from Ireland, mustering extra resources to bring someone with them and coordinating schedules. 98% of women who have abortions in Britain have their abortion free at the point of care. It's paid for by the National Health Service. And their care package also includes receiving a contraceptive method after the abortion, provided by the abortion provider, and also screening for sexually transmitted infections. For Siobhan, very different. She will have to pay out of pocket, and I've given you here the range of some of the prices, and it's gestational age dependent. So earlier pregnancy terminations cost less than later pregnancy terminations. So she could be looking at out-of-pocket cost just for the abortion alone of up to 1,500 euros. So what's the care pathway like? Well, it becomes quite similar for both of them at this point once they've actually managed to come into the unit. And the first thing is that they'll sit down and have a discussion with a nurse, typically, about their thinking about the pregnancy. Have they decided what they want to do? If they need to, they can speak with a counselor and have a discussion that is as long or as short as it needs to be about what their options are, how a pregnancy might impact their life, abortion, adoption, etc. Typically, there's a screen for domestic violence as well at this point. There is an association between domestic violence and having a termination of pregnancy, which is, I think, somewhat understandable on the woman's point, because if she is in a violent relationship and she has a child with the man who is being violent toward her, she will be linked to that man, essentially, for the rest of her life and her child's life, which could be dangerous for her and the child. Following this, there's a medical assessment that's relatively brief. I've talked about it in some detail in the paper that I submitted to you earlier, but it will certainly include an ultrasound in order to determine how far along she is in most cases, because that then informs the sorts of treatments that she could have and how they'll be performed, and some basic blood work, and as I said, STI testing. The blood work is very minimal, usually just a point of care finger prick point of care test. So when are most abortions performed? So we've just talked about the importance of assessing gestational age. And I wanted to show you the impact of women needing to travel, I think by and large, on the timing of their abortion procedure. And this is important because the earlier in pregnancy that you do an abortion, the fewer complications are experienced. So in the blue bars are the proportions done at certain gestational ages by weeks for women who are resident in Ireland. And in the purple bars are the proportions for women who are resident in England and Wales. And you can see that women who are having terminations who are traveling over from Ireland typically have them at somewhat higher gestational ages than women who are resident in England and Wales. And my interpretation of these data is that that is a reflection of the time that it normally takes for women to muster the resources, particularly the financial resources, in order to be able to afford to come over. The other thing that I want to point out to you is that the vast majority of abortions, even for women traveling from Ireland, happen in early gestation, so in the first few months of pregnancy. The proportion of abortions that happen in the second trimester and certainly over 20 weeks of gestation is very small. And those are usually for reasons of fetal anomaly, for example. It may be for women who didn't realize that they were pregnant. It may be for women who planned to have the baby, but then for whatever reason needed to change that decision. Maybe her partner left her, maybe she was diagnosed with a medical condition. There are a range of reasons, but all of them reasons that women consider in some detail. Following that, there'll be a discussion of the treatment options, what is available to her based on gestational age. And you have this picture in your submission from me, and it breaks down the methods by broad weeks of gestation, and then at the top are the surgical methods, and at the bottom are the medical methods. An abortion can be performed at any stage up to 24 weeks using either surgery, and usually that's a procedure through the cervix to remove the pregnancy, not like a cesarean section, not where you have to have an incision, or medically, meaning the giving of tablets in order to induce either a process that's very akin to a miscarriage in the first trimester, And in the earliest weeks of pregnancy, up to 9 or 10 weeks of pregnancy, women will receive those medications in the clinic, but the vast majority of them go home to pass the pregnancy at home. As gestation advances, they tend to be admitted to a clinic or to a hospital for repeated doses of medication. As the pregnancy advances in gestation, the induction typically takes longer. In early pregnancy, as I've said, surgical evacuation is also an option. It's done with a procedure through the cervix. It can be done with either local anesthesia, general anesthesia, or sedation. But as I've said before, if you've had any sort of general anesthesia or sedating medication, you need to have someone with you to look after you afterward. Dilatation and evacuation is the procedure performed in the second trimester. Similarly, it's performed through the cervix, the neck of the womb. That cervix must be dilated or opened in advance of the procedure, which can take several hours and up to 24 hours. So it is often the case that these procedures occur over a couple of days. So much as a medical induction in the second trimester might occur over a couple of days, so too do surgical procedures in the second trimester. Presuming no contraindications, a woman may choose between medical and surgical, depending on what fits best for her, and it's often the process of that termination and how it's going to be conducted that drives women's choices. For medical abortion, because there's often an interval between the two medicines that are used, mifepristone and misoprostol, that takes over 1 or 2 days, that's a limiting choice for women coming from Ireland because they have limited time to travel. It is the case in Britain that 2 doctors must sign a paper called an HSA-1 form stating that a woman is eligible for the abortion she is requesting according to one of 5 grounds. As Gilda has said, the most common grounds for which women have abortions in Britain are what are known as Clause C and D, and these are for mental or physical health reasons, either to the woman herself or to her existing children. And the definition of health that most doctors apply is very broad and akin to the World Health Organization definition, which is the presence of well-being, not the absence of disease. That paperwork may be signed just before treatment or may be signed immediately after the counseling experience. And then treatment is undertaken. So what methods are most commonly chosen? This is data from England and Wales, and it shows you that over the last 10 years, the numbers of women choosing medical abortion have increased almost year on year, and the numbers of women choosing surgical have declined year on year. Many women like the medical process because it's natural. They can have the miscarriage at home. They can have their partner with them throughout, or they simply don't want to have a surgical procedure or any kind of anesthetic. And so we have seen those proportions growing dramatically in England and Wales, and even more dramatically in Scotland. And this is the picture as it compares for women who are resident in Ireland compared to women who are resident in England and Wales. So on the left, we've got Siobhan and what she may choose depending on her gestational age. And you can see that at 3 to 9 weeks of gestation, when early medical abortion is available, and this is where women are given the tablets in the clinic and then go home to pass the pregnancy at home, a smaller proportion of women from Ireland take up that option than do women from England and Wales. So women from Ireland are not choosing medical abortion as often as women from England and Wales in those earliest weeks. And my interpretation of these data is that that probably has to do, as I've said before, with the need to have that treatment over 1 or 2 days, which means an extra overnight stay. And in addition, because those women would be discharged from the clinic after receiving the medications, they would then be managing the effects of those medications, which is pain and bleeding and passage of the pregnancy while they are traveling home. You can see that this is similar throughout the gestational ages, where women are choosing medical inductions or abortions less frequently than surgical, although it gets closer as gestational age advances to women's choices from England and Wales. Most surgical abortions can be performed in 1 day, and that is equally as appealing to women from Britain as from women who are traveling. With the increase in medical abortion in England and Wales, what we've actually seen is a progressive downward shift in the gestational age at which abortions are performed. So you can see these are the proportion of abortions performed by gestational age up to 10 weeks in the bars at the bottom, between 10 and 12 weeks in the green bars in the middle, and then at 13 or more weeks in the bars at the top for the past 10 years. And the numbers being done under 10 weeks of gestation have increased dramatically. And it is now the case that almost all abortions are done, as you can see, under 13 weeks of gestation, so in the first trimester. Some women will require aftercare. For most women, they are advised of the expected signs and symptoms after an abortion, whether normal or not normal, and they need to call for help. Most women don't have a routine in-person visit anymore. Their needs, for example, for contraception are addressed at the time of their counseling. And if women have a complication immediately after the abortion, usually that occurs in the first week, which is actually before older recommendations for routine follow-up visits, which were meant to be at 2 weeks. So how will this differ for Siobhan and Charlotte? Well, Charlotte's had treatment locally, so she's going to have local travel post-treatment. For some women, that may be an hour or two, and certainly it may not just be 15 minutes down the road, but it's not going to be air travel, which is the main mode of transport for women coming from Ireland. As I've already said, if they've had early medical abortion, they may be managing the process of that on their way home. That is true for women from England as well, because they cannot use the second medication, misoprostol, out of a clinical setting, although they may go home afterwards. Both of them will have access to a 24-hour advice line. Both of them will have access to the clinic telephone number if they need advice. But if they do need to seek care, women who've been treated in our units will be advised to come back to us. We treated you, we know how to manage complications of abortion, or if it's urgent, they might go to their local A&E or urgent care, where similarly people will be trained and knowledgeable about post-abortion care. Women traveling from Ireland, obviously, they cannot simply come back into one of our clinics to be assessed. They will normally have to go into unfamiliar services. And I think for women who are particularly concerned about issues of stigma or even being reported, they are reluctant to seek care. Most women feel a sense of relief after their abortion. Some women will feel sadness. Some women will need to talk to somebody about their experience. This happens. We offer women the opportunity to come back into our service and speak to a counselor face-to-face, or they may have that over the phone if they prefer. For women from Ireland, it's going to be phone-based counseling, which is actually very acceptable to most women. But for some women, they would like to sit down with someone face-to-face, which won't be an option, at least for our services. So I hope that's given you a flavor for what women in our service experience, the different experiences of women coming from Ireland and those coming and having treatment in Britain, and will help you actually in this, what I think is an extremely important deliberation. So thank you very, very much for your time.